Welcome to Vilnius, Lithuania.
Welcome back, everyone, to the ESC Live Studio. Today, we are discussing one of the most challenging questions or topics in contemporary dentistry, the clinical management of cracked teeth and root fractures. Those cases rarely belong to a single specialty, and successful outcomes depend on accurate diagnosis, realistic prognosis, and genuine interdisciplinary collaboration. The central question for today's discussion is how do we make the right clinical decisions together to maximize long-term tooth survival of such cases? And I'm very delighted to welcome two distinguished colleagues and friends from Lithuania, Dr. Tadas Venskutonis, who is an associate professor and head of the Department of Dental and Oral Pathology at the Lithuanian University of Health Science, and of course, endodontist specialist, also researcher and educator. And his work focuses on CBCT imaging, endodontic diagnosis, and treatment outcomes, making him one of the leading experts in evidence-based endodontic diagnosis. Welcome, Tadas. And Dr. Julius Maminskas, an associate professor at the Lithuanian University of Health Science, and also very well-known prosthodontist with extensive expertise in restorative and biomimetic dentistry, implant prosthodontics, and interdisciplinary treatment planning. He also serves as a chairman of the board of the Baltic Osseointegration Academy and is widely recognized for his evidence-based approach to contemporary restorative dentistry. Gentlemen, thank you both for joining us, and let's start our talk.
Good evening. Yes, thank you.
Good evening.
So,
why it's a challenge for endodontists, also for other specialties, for general dentists, because probably the crack, it's not a disease, because we are used to diagnosing diseases, and the crack is a structural defect, which gives us some biological consequences, and we cannot measure its depth, and it's hard to measure its propagation. And the problems from our specialties that it's difficult to find. It's rarely seen on dental X-rays, only a few % of them. CBCT, it's a good tool, but again, it's the resolution is still not there yet. The longitudinal cracks are small, especially if we have some root canal treated teeth. So we're not seeing usually what we are looking, some kind of bone consequences. So we're not looking for direct cracks, but what's the consequences of that.
And secondly, I think that we should realize if we have cracks, more or less, it is not a primary treatment. It is a retreatment of the previous procedures. So when we have retreatment, it's really difficult to prognose, and it's really difficult to predict the final results.
Yes, and I know that you collaborate together extensively. You work together as a team, let's say, in general. So again, my second question is to both of you. When you first see the patient, when you first assess the patient with a suspected cracked tooth, what is the primary clinical question your specialty is trying to answer in general? Are you both trying to answer the same questions, or are your priorities fundamentally different? And this is, I think, it's an essence of two specialties, yes? Do we communicate together in the same language, or are we looking at the same, let's say, problem from the different perspectives?
Yes, actually, Laura, it depends where the patient came first, and that's the true. But in our opinion, all the diagnostic procedures should start at the chair of prosthodontist. Why? Because at the end of the treatment, we are in charge of the results. So if the patient is coming with complaints, at first they are coming to prosthodontists. So that's why we are starting, and that's why we are starting not with a diagnostic by using only X-rays and clinical views, but more or less we need to start with an intervention in order to check the real situation after removing of old fillings, of carious lesions, demineralized structures. And only then we are able to evaluate the perspectives, prognosis of the remaining tooth structure. Only then we are able to plan necessity of clinical procedures, and only then we are able to explain the patient what can we do.
Tadas?
Yes, so probably as you ask, is perspective is the same. So kind of the tooth is the same. The patient wants to hear prognosis, probably total prognosis. So
Yes.
from prosto, probably what Julius also explained. So perspective from prosto is, can this tooth still carry a load? Will it function? From endo, from our point of view, we are looking into those cracks more or less as a portal of entry of microbes. Has it gone inside, or how deep it went? And then we're looking if so. So from endodontic point of view, like we'll need to assess three things: pulpal status. Okay, it's normal, reversible, irreversible. We're looking, do we already have some periapical disease? Maybe it's already necrotic, or it was already treated. And of course, we're looking in periodontal status pockets, because we know that maybe we'll talk about a little bit more that probing is the most probably prognostic factor. So probing is one of most important things, and of course we need to somehow, it's difficult to differentiate, okay, which of the crack is important, which not, which is just a finding, just okay, we have cracks which already needs something, and probably it's either we have symptoms, do we have some change again in the pulp, and structure, periodontal. So those three things probably will lead us to decision: do we need to do something invasive, or maybe we can monitor, or just follow up with some
So
restorative.
That was supposed to be my third question, because when we see the patient, when we see the crack, we have to talk with the patient, yes, and we have to predict success or failure somehow, yes. So at what point do you feel you have sufficient information to predict prognosis with reasonable confidence, let's say like this? So Tadas, you already started to talk about the...
But probably in the beginning, like if you see the patient,
exactly.
If you see the patient initially, maybe you are not suspecting a crack. Maybe from some symptoms, okay, maybe you already have some X-rays. You could, but let's assume that there's no signs, and you go inside. Like Julius told, I don't like to be the first which goes inside, especially if some kind of a big restoration. For me, it's better to have a plan, other person which already took care of some defects. But let's be honest, sometimes, yes, we need to do, especially in those cases when the patient seeks help, it has some pain, nobody's finding what's causing, you see x-rays shows nothing, every tooth have some restoration, more or less it's good, and you need to decide, okay, maybe probably this one will be the right one you're removing, and you're finding some crack. And probably for me to make decision, again, most like we need to bisect, we need to see which of the risk factors we have, yeah. And if we know that periodontal probing is one of more important, so we need to do that. So if we have a pocket, we already know where we have no pocket, okay, we're going how many cracks, location of those cracks, do we have extension to the root? So again, if I'm not going inside, or if Julius are not going inside the tooth, we don't know how deep it's going. There's no way to see. Maybe in split tooth, when two fragments going, we already know what we will find.
Donald is talking, this is I think at the beginning when we find those cracks, yes? This is quite a problem for us, first of all, how to communicate to the patient. Because we already started the procedure, we already talked about something else that we are going to retreat the tooth or treat the tooth, let's say, and something like that. And suddenly we see the crack, and that it's not pleasant finding, I guess, yes? So, Tadas?
Yeah, so like I told those risk factors, and probably if I'm finding something, we all need to have those maybe stop criteria, when to stop. Usually if you started or I'm starting, so the point at which I want to stop doing something, it's new information, of course. If I talked with the patient before, we agreed with the treatment, and in that treatment was no crack, and you are finding, of course, everything changed, the prognosis changed, probably restoration is changing. So of course you need to stop, you need to talk with the patient, because the patient is the one which needs to take that informed decision, not us. We just consultants for it. So probably I will give to Julius, and he will evaluate maybe other things.
Okay, so who should lead the initial treatment planning? Julius. Who should take the lead in the initial managing of the cracked tooth? The endodontist, Tadas, he said he doesn't like to do that. So prosthodontist.
Yes, actually, as I said in the beginning, everything is starting from the revision. Only after revision we are able to accept following decisions. And yes, we need to clean, we need to evaluate, we need to determine and to accept the final treatment plan, including final restoration and etc. And for sure, after a revision, we need to perform the restoration of walls in order to create the ceiling, in order to create the reinforcements. And only after, with our requirements, we are sending patient to endodontist and asking to continue with the endo treatment if these procedures are necessary, because sometimes when we have the vital tooth and when we have the crack, and after the reinforcement, after the sealing, if the symptoms had gone, so it's unnecessary to continue with the endo treatment at all.
Yes. So we already started with Tadas to talk about when the situation is changing, then the scenario is changing during the treatment. So if the tooth is referred for the root canal treatment, for example, to endodontist, and of course preoperative assessment appears favorable, and during access cavity and preparation of the root canals, we finally find that there is a crack extension further than expected. So, Tadas, at that moment, you said you stop, you start new conversation with the patient. But Julius, how does this new information alter the restorative prognosis? Do you do you start a new planning, or what kind of decisions you are taking at that moment?
Yes, Laura, it's a very good question, actually, because the worst thing is when the patient is coming for the restorative procedures after endotreatment, and we have the crack somewhere. So yes, the endotreatment was done, was performed, but sometimes it's unable to continue with the restorative treatment because we don't have the restorative perspectives. We cannot prognose that. Sometimes it happens. So yeah, and that's the worst thing. Yes, always I think that communication is really important, and the collaboration is really important when we're dealing with a cracked tooth between endodontists and the restorative specialist, because only in this way we are able to find the best decisions.
Yeah, and usually I think you do the same. If you find some new information, probably Tadas, you can make a video or you can make a photo and send to Julius. Probably you are doing these things and you are deciding while the patient is even in the chair what to do, to continue or to stop, or to do some kind of a new conversation or new consultation and taking a new decisions.
Yes, and what I can add that I'm lucky that Julius also working with microscope. Yeah, with microscope, and most of the restoration also is done under rubber dam. So and to be the advocate of resto first, if we see some kind of crack and it goes from proximal area under restoration. So if we want to assess it, of course, we need to remove restoration. So what does that mean during endo? If we will remove restoration, we will not have walls and we will not do endo. Yeah. So definitely we will stop. So if prosthodontist starts, because we like, when we talk with Julius, we're talking like in the beginning, if we want to make good prognosis, we need to see the tooth naked. That means remove of all old restoration. Then you see what's left. Then you can make good decision how to cover it. Just direct, indirect, and so on. And also you will find some defects, cracks beneath that restoration. And then if Julius sees that, okay, it's good to go, and he builds something, usually I'm not seeing that ending of the crack, just what's going to the pulp, if I need to go. And the literature also shows that most of the reversible pulpitis cases, you don't need to do endo at all. So maybe 2/3 of the cases I'm not seeing at all. Julius just cleans, restores, and that's it. So that's also a plus from prosto the start, not from the end.
Yeah. And now both of you, just imagine you have a cracked teeth and you decide and the patient decide to keep that tooth. How you as a specialist, as a doctor who will be performing a root canal treatment and also the restoration or some subsequent restoration or before the endo restoration, what are you going to do? How are you going to treat that tooth? Are you going to treat that tooth differently than, let's say, tooth without the crack? Or what is your clinical approach to that cracked tooth, let's say, that we are going to save?
Okay, so the first step is the definitely revision. After at the same procedure, we need to restore the defects, to reinforce by using adhesive systems and to seal everything. And then, if it's necessary, the endo treatment should go in the next step.
Tadas? Minimal invasive?
Probably,
Preserving?
if we're talking about primary endo, like, okay, it's not root treated, so probably more or less will do the same, because we always in primary, we want to preserve pericoronal dentine. If already some assessment from prosthodont, okay, maybe it's removed from occlusion, or occlusion is balanced, we have some coverage. So, and we're talking about probably like how to maximize success in our treatment. Of course, first thing is case selection. Yeah. So if a patient wants to keep that, but it's hopeless, so we can do whenever we want, that will not work. So if it's doable, like, okay, all the pocket is not too deep, and the crack is not split, so probably we will try a little bit more conservative. The problem will be probably the selection of materials. If we have something, the crack inside the root, so still the literature, it's not those studies which done, some of them done with composites, some of them with biodentine, and still we are not have some pooled data which of them is best. So it's either by gut feeling, okay, this case will be with this material, this case with this material, but probably again, fracture is more or less load cause. So first thing to balance occlusion, parafunction, and so on, and then from endo try to remove bacteria and seal as good as possible.
Okay, so we started to talk about the evidences, and probably there is not so much to say about that, because still the gaps exist. But still, what let's say, which aspect of cracked tooth management are currently supported by strong evidence, and where do we still really rely primarily on our clinical experience?
Okay, so probably
the materials, it's a gut feeling, yes.
Yeah, it's probably like in all endo, we don't have enough good supported material. Yeah, if as free guidelines, more or less all of them are not really good. Yeah, so what's reasonably supported? So we know that cuspal coverage that improves, that periodontal probing, it's really good predictive value. We now this year came a study 10 years, 15 years. So we know that cracked teeth can stand for 10, even for 15 years. Okay. That prognosis at 15 goes to 37%. That's not good, but still 15 years. Who could imagine? What is not, or what is more clinical judgment? So probably we still don't know direct versus indirect. We still don't have any methodological how to measure severity of a crack, how deep it goes. Still, we don't know timing, how fast we need to rebuild both therapy on cracked teeth, because all of the data comes from more or less from caries, open teeth, vertical root fractures. Okay, right now, okay, if it's fracture, more or less extraction or removal of the root, then we need to monitor or intervene, because we know that only part of the, maybe up to 10% of the cracks propagate, some of them are not. So then we need to go inside. So more of the questions still are not answered than answered.
Exactly.
Yes, and actually, when we are looking from the prosthetic point of view to that question, yes, we have plenty of studies, but the main problem sometimes is that we don't have uniformity of studies. Yes, we have studies about selection of restorations. Some restorations retentive-based restorations, some restorations are adhesive-based restorations, and we need to realize that we cannot compare both of these selections. Also, we cannot compare the adhesive restoration made with rubber dam and without rubber dam, and etc. And yes, from evidence-based, we have some questions, and sometimes when we need to accept the clinical decisions, it is difficult to take a look only at the evidence-based data.
And closing our discussion, our talk, if you were designing the ideal interdisciplinary clinical pathway for managing cracked teeth, from the patient first examination to the definitive restoration, what would that path look like?
Probably
What is
if we
the
talk
best?
about...
Who has to start? Who has to follow? Who
So
has to finish? Who has to
we
follow
talk
up?
probably that Julius Prosto needs to start. So from the crack perspective, yeah, so you need to detect, you need to map, then you need to do pulpal, periapical, and periodontal analysis and diagnosis, then structural occlusal assessment.
So that's for
And
prosto, yes?
Yes, that's prosto. First, probably detection of cracks. Usually, if it's not like from both classification, first four, it's coronal origin. Yeah, so both
Yes.
coronal origin, prosto will always detect. Probably the prosto will not detect the longitudinal fractures which are inside the root. But usually, if it's inside the root, we already have something on X-ray. So X-ray might tell you that something is going on, and probably that will be a stop criteria for Julius that, okay, something is not right in that tooth. Can you look? But if it's coronal origin, most of the time prosto will see it and will make the right decision, either maybe extraction at that point already. And then if we have periodontal, pulpal, periapical, and occlusal assessment, maybe then we can make one diagnosis based on both those domains, and to tell the patient, okay, we think this is the right way we will do, because at this point we need to make decision, either we monitoring, going inside, cuspal coverage, do we doing root canal or do we doing retreatment, and of course as soon we can do that sealing. So that initial Julius what told that initially he is sealing doing as soon as not especially in not cracked teeth, then we started 10 years or 15 years ago do like prosto first. We saw that there is no fractures of fillings. Maybe you can have a little bit longer period between appointments because that tooth is already maximum adhesion, and you already like have insurance on
Protected,
that.
yes.
Of course, it still could happen.
Of course, yes. So in a way, the prosto starts, then you continue, and then the prosto takes it over, and then
Finishes.
the follow-up, it's up to prosto.
Both, yes. It's a good question. Usually, prosto likes to make good pictures of their restoration. So the patient tends to come to prosto more often than to endo, because endo, they've done something, it's not visible, it's not nice, and it costs, so they tend to go to prosto more often. Somehow. I don't like it, but that's reality.
Still, we are talking about two specialties, but sometimes there can be also perio specialty included. So I think the final result anyway will be done by, or the final restoration will be done by prosthodontist, and prosthodontist probably will see the patient for those checkups, and of course the endo status and perio status should be included in the checkups, if you agree, Julius.
Yes, I totally agree that during the follow-ups we need to perform probing in order to check for the pockets, for local pockets at the area of longitudinal cracks, and yes, if we see that we have an extension of the pocket, we always need to ask for our colleagues, periodontologists, to take a look to determine and to accept the decision together. Because more or less, when we have the increasing of the perio socket, we can expect that our crack is also increasing. And I think that during the follow-up, this kind of criteria is becoming as a result of unsuccessful treatment at the end.
Great. So we already running out of the time, 5 minutes, but we can talk about this topic for hours, I guess. However, you are giving a lecture during the ESC autumn meeting here in Vilnius in 2006, October 23rd, 24th October. So we really invite everyone to listen to your lecture, of course, and to have a discussion, very profound discussion on site. So thank you very much again for dedicating your time for this nice interview. And we can say that we'll see each other very soon, in a couple of months. So thanks a lot. Thanks to everyone who is watching us, and see you very, very soon. Oh, we still have one question, if we can take that question. There is the line where cracked tooth, vital or previously endodontically treated, cannot be saved even from the most motivated. Where is the line where the cracked tooth, vital or previously endodontically treated, cannot be saved even for the most motivated patients? Where is the line? We say, sorry, you want to keep this tooth, but it's not possible.
In my opinion, from the prosthetic point of view, in our days, we cannot continue with the upcoming treatment if we cannot ensure the sealing of the crack. It means that if the crack goes deeply into the root and we cannot hermetize it, or if we have the interconnection of cracks at the mesiodistal area and etc., so we cannot expect good prognosis. And it's, in my opinion, it's not logical to continue the following procedures.
Tadas,
Yeah, so
anything to add?
probably I will agree. The crack in the root, especially that would be called like vertical root fracture. If it's from the end, so okay, that's no go. If it's from coronal part and we see that crack is active, like okay, it's quite big, we have some bone loss, and we really see okay, the Julius will prosto can seal up to bone or up to gingiva level, and beneath it's a gray area, which okay, we can put some kind of material. If the patient is very motivated, we know that okay, we will prolong that tooth for a very short period of time, but as a consequences we might lose more bone.
Yes.
And if that losing of that bone will make not good prognosis for implant and so on, so probably that's not worth. So we need to wait that okay, the patient wants to save it, the money is on their side, but still later the implantologist will not help us and will say why you did this. So probably the pocket more than 6 millimeters and active crack, it's no go.
Unfortunately, we are not gods, so we have limitations, and some tooth we cannot save. So thank you very much. Thanks to everyone, and see you very soon.
Yeah,
Bye.
see you in Vilnius. Bye.
Thank you, colleagues. Goodbye. See you in Vilnius.
See you.